Alrighty, so next up on the list for LVNs, this can be for RNs too, but I'm primarily gearing this one towards LVNs. We're going to be doing nursing progress notes. Oops. There we go, nursing progress note. This will be for both regular visits and PRN visits. Regular, and I'll show you the difference. So new record. Let's put in a time. Today at a couple minutes ago, and then we'll do now. Okay, and so, as you can see up here, we have in-person, telephone, telehealth, and then this little drop down right here is where we make our decision on what kind of note this is going to be, or what it was for. As a word of this little pop-up right here, as an FYI to everybody, is that, just put yes. Because honestly, this thing is part of their scheduling setup in here. I don't personally really like, and nobody uses. And so you gotta, was this authorized? If you do no, then you gotta go through all this. You gotta put my name in, wherever it may be in here, and so on. Just put yes. Continue. Okay, so got that. We go over here, and depending upon the visit, the type of visit, this is what you do for your stuff. So let's say you have your regular nursing visits are right here. These ones I would have be for your PRNs. So let's do, I'll just show you the PRN real quick. Oops, or another. So for the LVN, other visit, you put the reason why you basically went there. Let's say the patient was constipated. All you got to do is vitals. You're going to do all these BP, sitting. What you're not going to do is you're not going to alter these guys. These are for the RN usually. Okay. Even RNs aren't always filling these out. Like the height and the weight, it's very difficult to get something accurate, and it's not like they're just weighing people willy-nilly at facilities or at all, especially at the home. So most of our patient populace has a real difficult time getting weights. Usually we go off the mid-arm circumference, which is 2 inches above the antecubitum on, and it's usually left. You want to make sure that it's on the same side every time. But we got that. O2, well, it's on room air, whatever, and then the narrative. Pretty straightforward. It's not a whole lot to do. Basically vitals and reason why you're there, and then a narrative, and you're done. So that is the other visit. That's the visit I would say is primarily for PRN visits. So for routine visits, usually the LVN does this one, which this one's got a whole lot more to do, but it's all in the form of check boxes. So it's not really that much more. So let's go down the list. Start off, this one's got a pain one. Pain is controlled to the comfortable level of the current intervention. Yes. Pain level reported at visit, 0. If it's no, then, pick whatever pain it was, so on. But physical pain assessment, assess as needed. Really, you already assessed. What I would do is I would just include in the narrative, because it becomes a redundancy when you start doing all these other drop boxes. And I'm not too much of a fan personally of redundancy within charting, unless it's like, well, no, redundancy is just in and of itself unnecessary in this case. So we got that. Temp, already went over that just a moment ago. And this is all of your little check boxes. This is all your little things. And don't be overburdened by this. It's not really, or overwhelmed. It's not really that difficult. So one principle of this is that you assess for all these different things. This is basically head to toe. You assess for all these things. If there's nothing going on, assess no issues reported. Boom. A lot of our patients are confused. So let's go down the list on this. Anxiety, depression, agitation, confusion. Obviously confusion. full dementia, obviously confusion, speech impairment, severe. And if there's other symptoms, go ahead and place the other symptom in here and go ahead and rate. And this rating system is based upon how it affects the patient. How, let's say the patient, at least this is how it explained to me. Say the patient is only eating 10% of what 10% of their meals. If they're not having any issues, they're not feeling super hungry, it's not like an actual problem, then you put none. They're not actually having any issue. They're not feeling much of a symptom from that. I would state, patient eating 10% of meals denies hunger. Weight loss, 2 pounds last month, whatever. You put more defined descriptors within these areas right here, or you put in the summary at the bottom of the page. So got that. Go down through this, got those things. Cardiovascular, let's say that this patient, all they have is Alzheimer's. They don't have any cardiovascular disease, which is respiratory. Let's say they get short of breath while they exercise. Got that. And if they're getting short of breath while they exercise, they probably are pretty, probably pretty fragile. Or if they get it at rest. So immune infection, or if they have an upper respiratory infection, then, URI, how bad the symptomology is, if they're short of breath through their infection or they have RALs, you might put moderate. If they don't really have any shortness of breath, they just got a sniffle, mild, so on and so forth. GI, let's say usually, even if they're, usually all of our patients are incontinent, it's not usually an issue. I would say incontinence is an issue if it's like a sudden change, sudden detriment, and they were caught prior, or immediately prior, and this is just a change of condition, change of capability, because it denotes, obviously, if a person is going from continent to incontinent, there's been a decline of some sort. So we got that. We always try to have the last bowel movement, in the sense of we always try to denote when it was. And yeah, that's that. If it's been super late, say it was over 3 days ago, then that's where we would state, like, uncheck this, we would state like constipation, moderate, mild, moderate. And usually if there's an issue, we state how we resolved it. So down in the bottom in the summary, if we go down in the narrative, that's where you would say, like, last BM was 4 days ago, administered suppository. Got that. So go through this. Usually most of our people have, we've had plenty of pegs and tubes and whatnot, but we even had TPN. But usually this is no. Always make sure to fill this one out whenever you're passing through doing doing this documentation. Diet, whatever it is, endocrine. Usually, if you assess whether or not they have a just an endocrine disorder like diabetes, something. If they have blood sugar, you go ahead and state what the blood sugar was, that sort of thing. Most, we have a few diabetics, and we have a couple that require blood glucose monitoring. But otherwise, if you don't have the information, it's not available. You're not required to by the physician to be doing like a point of care blood glucose. Then don't worry about this stuff. Just assess whether or not they have any symptomology. Let's say if they're a diabetic, if they have any symptomology of exacerbation, like increased thirst and so on and so forth, or if they, for instance, look like they're lethargic and whatnot for hypoglycemia. Next up, GU. Like same thing with the bowel movements. If they're incontinent, it doesn't necessarily mean that there's an issue. It's more so if that's their baseline, then that's their baseline. Your concern is if it's a sudden change, or if it's been if it's a change, they start having more accidents, so on. You need to denote that because that helps the rest of the staff understand, and including the physician, basically why they're on hospice. If they have like these, you need to have this continuum of decline. Not need to. The hope is, of course, that everybody gets better and everything is all good. But for Medicare's sake, if they have questions about a case, it's a matter of whether, you know, we're here because the patient is declining one way or another. So you need to denote what kind of declines they have. Next up, sleep rest, pretty straightforward. Musculoskeletal, pretty much everybody, as an FYI, everybody has weakness to some degree. Now, this is whether or not the this rating system is to denote whether or not the weakness has an effect on their overall, on their ADLs, for instance, if they can walk or not, if they're non-ambulatory and so on. This is where that kind of stuff comes in. So a lot of our patients have difficulty walking. In fact, almost every single one of them has issues with ambulation and so on. They have weakness to some degree. So that's that. Contractures, same deal. Whether or not they have contractures, how much they're affecting the patient, and so on. What you did, if you did a hand roll. Skin is a big one. So we don't have too many wounds, but we have the occasional wound, of course, some of them worse than others, very much worse than others. Let's say we have a patient that's got a stage 2 on their sacrum, like pretty typical. We're not going to do this. If they're free and clear, then yeah, we click that. Even if we click that, we got to do this part, wound assessment. Full wound assessment, due every 7 days. Now we have, our patients are seen twice a week, usually by the nurse, which does the wound assessment. So by a visiting nurse, including sometimes yourself, sometimes the RN. So, you do it 7 days past the point of your assessment. So that would be the 20th, because today's the 13th. They got a stage 2, make sure that's unchecked. Got a stage 2. Sacrum, 2, size is 2x3 cm. Color pink, you use this table right here to denote. Now let's say it's like reddened, you can do reddened. And that's all fine and dandy, because really you're just trying to have an honest descriptor of what it is so that you have something to go off of documentation wise. Color, drainage, the legend right here, serosanguinous, color pink. Odor, none, or let's say mild, it's on the butt, why not? Mild, peri-wound. This is just basically this is the area immediately surrounding the wound that does have some semblance of damage or deterioration, but that is not to the degree of the primary wound bed. So let's say it's usually, I like to say, like what it is, the diameter outside of the initial wound. So let's say this is 2x3. I usually do something like 2 centimeter, for the reddened area that's around the wound. Undermining, that is a measurement where you're measuring the end of a like a swab or something to find out the depth of the wound bed underneath the initial visual involvement. But undermining, let's do 0. Yeah, you're supposed to do recording via clock orientation. Comments if there's anything else you want to know. Now see this part, additional notes, summary visit. This is actually like an appendage, a useless appendage of the prior version of this EMR, because pretty much you have the narrative right here. This is just more so additional notes, not summary of visit. Collaborated, I always want to say who I'm working with, especially within a facility, so that I could say who I had reported off to or whatever. So let's say it's the Director of Nursing at Sunrise. There you go. Or Wellness Care Director. She's an LVN RN, I can't remember, but you know, PCG Sarah. Okay. Plan of care reviewed with. I mean, usually you're having a chat with the patient like pretty much every time. You're supposed to call the families. It's based upon whatever your relationship with them is, whatever their request is for how often they want to be contacted. But usually you're reviewing POC with patient family RN just about every time. RN is the one that's usually contacting hospice, but it's usually those ones and almost always facility staff. You know, at the end of every visit, when you're within a facility, you go over to the facility staff members, you report off, discuss the case for a moment, and that's your POC review. Yeah. So got that. Medication's adequate until your next visit. Yes. Order written for new med treatment. If there's a new wound, then you would say yes, and you would do your. Well, you just say yes, because this is which medications are ordered, refilled. If there's no orders, then that's it. You can put, you know, wound care or something here. Instructed patient caregiver regarding med regimen, administration, pain scale, understanding, yes. Usually you check DME, you do all these things right here. Patient education, our main job. Purportedly, patient CG states understanding of instruction, hopefully, and then labs drawn. We almost never do labs. You know, it's usually not necessary to be poking a person when you have nothing you can do about the results. And not available because those are for critical values, which we don't really mess with because you have to draw the labs in the first place, and usually critical values are like, I mean, it's hospice. So next up, mobility. Ambulatory, non-ambulatory. A lot of people miss this part. There's a little checkbox right here. Yeah. So make sure to click whatever one is which. Ambulatory is they still have the capability to move themselves around even if it is with an assistive device. So ambulatory, wheelchair, moderate assist. Transfer bed to chair. This is an interesting part because they have non-ambulatory and this is all the stuff related to it. I kind of see that a lot of things within both can be applied to each. So let's say they're non-ambulatory, but they're usually wheeled around in a wheelchair. You know, they get them into the chair. You know, I have plenty of patients that can't maneuver themselves with the wheelchair, but they certainly can have assistance for caregivers to get them into the wheelchair and move them around. I count that. They're not ambulatory themselves, but someone can get them around. Transfer bed of chair, you know, that would be if they can transfer themselves to a degree. So the patient I'm thinking of in particular right now cannot transfer herself at all whatsoever, but they do transfer her to wheelchair and then move her around with that. ADL assessment, pretty straightforward. You have your scale right here, and you state what you do, which is, you know, on that scale for those things. Imminently dying, hopefully not. Fall incidence occurrence, nope, for now. Of course, if they do have one, then not only do you put yes, but you also want to put I wouldn't do this part. Like I said, more redundancy. This is already done for it's already done within the assessments with the RN. And if there is a fall incidence, then you go to do an incident report, which I can show you in a further video. Usually you're not the one messing around with this stuff, the KPS, PPS, FAS, and MyHA. That's all for the RN. Usually you just put non, as in like this is to register that there was a change from prior day. If you really want to, you can assess what was from prior. You know, take a look at the prior note and see how it matches up, but I know that for the most part you guys won't be doing that. You'll just stick to this. Let the RN deal with that portion. And then of course we have the visit checklist. Usually you do all these things. The only thing you don't usually do is checking Foley's. Like, you do it if they have it, but only a very small percentage of our patients have Foley's. GI tube, yeah, same deal. Confirm schedule of next visit. Yes, I have. Okay, and there we go. Got all that pretty much filled out. That took about, looks like 15 minutes or so, and that's me going slow. That's me describing everything and all that stuff. You also have to do the narrative, but honestly I finished these guys up in about 10 minutes. So yeah, do the narrative and sign it. When you when you go to sign, you sign and send the QA, click yes, and that sends it to me for approval. But yeah, that's pretty much it. Don't worry about this care plan part. Usually the RNs are the ones dealing with the care plans, because that's our, that's just our thing. And yeah, I think that's pretty much it. Don't forget you have both versions. This one is if you are a routine nurse, and this one is if you do PRN visits. But okay, well, thank you.